I think most of you know me. I'm Margaret Arnold. I'm the CEO of earlymobility.com. And I'm a physical therapist by training, and I am passionate about getting excellent outcomes for all of our patients, but particularly our patients of age. So this is very near and dear to my heart. And Janice, I'll let you introduce yourself.
I'm Janice Humala, and I am a senior advisor here at earlymobility.com. And I have seen through my, never mind how many years of work, so many employees being injured, so many patients staying in bed because nobody wants to lift them out. Not much of an understanding in that area. And I've had the pleasure of working with Margaret the past few years and doing gap analyses and coming up with problems and overcoming challenges. And it's really, really rewarding work and, helping come up with how we can move forward and make it beneficial. Margaret, I'm gonna let you go ahead and talk about the objectives.
Yeah, so we're going to just give a little bit of background on why age-friendly care is such a strong initiative. Why is CMS adopting it? Talk about what the age-friendly care requirements are, because I know there's been a lot of question about what do we need to do? What will inspectors be looking for? What are our timelines? When do we need to meet them? What are some of the specifics? What happens if we don't implement age-friendly care? And then we're going to talk a little bit more about how programs integrate. And one of our favorite things when we go into facilities is breaking down silo walls, right? And so one of Medicare's initiatives with this program is that it shouldn't be a separate standalone, that we should look for ways to integrate with what we're already doing to seamlessly integrate these principles of age-friendly care, which we'll jump into. And then we're going to talk some specifics. We're going to go through a case example and show you just how your Safe Early Continuous Mobility program can check so many boxes, including the age-friendly care box. So, and then lastly, we're going to just give a little bit of information, tools, resources where you can find more information, because there's so much on this topic. It can get a little overwhelming in the literature. Have any of you seen this? A 91-year-old gymnast. And so our point here, as I watch this always makes me chuckle, and it just reminds me why we are looking at this today. Not all people of a certain age look the same, act the same, have the same kind of lifestyle. This lady is 91 years old. 91 years old, right? She's absolutely incredible. Janice, if you can just skip forward a little bit here, she's on the parallel bars. And when we think parallel bars for gait, this is not how I think of using parallel bars, folks, right? Let's look at this in our rehab gyms and set goals for our patients. Let's set these goals for our 15 and 20-year-old patients, let alone our 91-year-old patients in our parallel bars. So again, if you haven't followed this lady, unbelievable what she can do at 91 years old. And so again, what matters to her is going to be very, very different to what matters to many other patients that same age. Yeah, I can't even do half of that now. So let's go on to the next slide, Janice.
So first, let's start out by trying to get a collective definition or idea of what age-friendly care is. And age-friendly care is a movement, and I love that word, that seeks to improve the care of older adults by understanding and prioritizing their needs and their preferences. So we need to look at a lot more pieces when it comes to elderly people that sometimes we don't tend to look at, and this really helps us focus in that area. There are within the concept is 4 essential tenets for measures that we need to consider what matters most. And we're going to describe these more as we go through mobility, mentation, and medication. And these are pieces that are all important, even now, today, but yet getting them all documented and making sure all the pieces are there are sometimes what the challenge is. And part of what we hope that you take away today is most of these measures, most of these actions that are being taken, look around and figure out what it is you're already doing and get a clear documentation and a clear understanding of that. before you go ahead and start adding measures. The measures aren't meant to be so burdensome that you have to start from scratch. One of the great pieces about that is that early mobility fits so well in with these 4Ms. So what are some of the harms that we see when older adults are in the hospital? They can have falls, pressure injuries, delirium. I know I'm preaching to the choir here. Incontinence, your UTIs, DVTs, and pneumonia, and it's from immobility and polypharmacy. Sometimes they can be isolated and feel isolated because they're neglected by their caregivers. And that might be for a lot of reasons. It might be from the communication challenges. Maybe they have a hearing loss or they don't communicate as well. Maybe they don't speak as clearly or as quickly as we're used to hearing. Maybe they're actually getting care that they don't want, getting more than what it is that they would like. And with all of these other challenges, it can result in them feeling isolated, having a loss of social interaction. So what happens is people can also have a psychosocial and emotional impact, right? They can have anxiety, depression, loneliness, fear, grief, anger. And we have these on the slide so you can see those. You know, what's sobering to me is this statistic that in 2022, out of the almost 50,000 suicides in the US, over 10,000 were age 65 and up. That's a huge number. A lot of us think about teens and, you know, people in the early 20s and 30s. And this graph here is not going to be a surprise to anybody, right? Because our older population continues to get larger. And in fact, by 2030, we are expecting that the number of adults age 65 and older we're going to have more of those than we are going to have children under 18. And that will be for the first time in history. So one of the terms they call it is the graying of America.
And I think many of us are in that group already or rapidly approaching it, right? So this is particularly relevant because this will be the care that we are looking to receive ourselves.
Speak for yourself, Margaret. I'm just getting more blonde. So one of the pieces that they talk about with your 4Ms is that not only do we need to do an assessment and figure out what it is, but we also need to take action on those, right? It's not enough to simply figure out what pieces that we have and what we need to do. What are we doing about them? So there is a timeline that CMS has. Basically, it starts in January, and by December 31st, your top person would need to attest, which means sign off. So essentially what this means is that we work on our measures and figure out what those are, and they need to be attested by December 31st, 2025, so that they can start the actual recording, the measurement period in 2026. Why is it important? Well, first of all, there are significant penalties. They're expecting it to become a pay performance measure. And for 2025, when they start measuring that in 2026, hospitals meeting quality and meaningful use reporting requirements get a 2.9% update in reimbursement. Well, if you don't meet the reporting requirements, that can drop down and you can lose approximately a third of the update. Not third of the total, but a third of the update. And what does that mean? Well, here's 3 different size hospitals. On the far left, you see there's an 800-bed hospital. If your total previous year Medicare revenue was 383,000 plus, if you got the full update, you'd get 11,000 something. If you got the reduced update because you didn't meet the needs and requirements, then you would be getting 7,800. I'm sorry, 7 million. And that's a loss of approximately $3,264,000. So how much this impacts you certainly is based on size. The 186-bed hospital, this example shows 202,000, and a 25-bed hospital shows 22,800. But I tell you what, for a 25-bed hospital, that's a lot of money that they could use for other things. There are benefits in addition to getting the amount from CMS. And here's 3 examples. I'm just going to pick the first one, and the rest of them will be in your slides. So basically, these are success stories. So this is an example of a program for older adults in the Cedars Sinai Medical Center in LA, California. What they had, the benefits of age-friendly care, it has been an 11% reduction in length of stay, 41% reduction in time of surgery for the geriatric inpatients, $300,000 in direct cost savings, and a projected $1 million savings as the program expands. We have seen this ourselves in the programs that we have worked with. One of the programs that we're working with right now is, even in the first 3 months, they were saving $30,000 a year, and they're slated to save $500,000. And this is only one unit that they have been really focusing on. So what will inspectors look for? So as we figure out what we do, and we also want to figure out, how do we communicate this? How do we show that we're doing what we say we're doing? First of all, they'll interview your employees, your colleagues. And what they're looking for is the staff going to have the same explanation for why you do the 4Ms work? So when you do the teaching, make sure you include why this is important. Will they use the same explanation for how you do the 4Ms work? What are you looking for? What are the measures that you're taking? How do you document that? Staff at your site will have documentation for the 4Ms work. They can access your 4Ms care description, which means you need to have a 4Ms care description, and any additional standards supporting operating procedures, flowcharts, checklists, etc. So that needs to be available. You can have training and orientation for employees, job descriptions that outline the elements of the 4Ms work as appropriate, obviously, to those roles that it affects, and performance evaluation also refers to the 4Ms work. So it's really providing education, awareness, consistency, and accountability throughout the process.
So yes, many of you have seen this graphic, right? This is the standard. When all of us think of 4Ms, age-friendly care, this is what we look at. And we're going to have some repetition with what matters most: medication, mentation, mobility. This is the framework. We'll probably say it several more times before the end of the presentation. But again, these are the core tenets. So there are 5 domains and 4 Ms. And the domains are eliciting healthcare goals of the patient. That's what matters to the patient. There's responsible medication management. And we all know the idea that we have in our heads of a senior person at home with their medication is lots of pill bottles and trying to figure out what pills I need to be taking. And then I've got this medication to counteract the effects of that medication. And then this one causes me to feel nauseous. So now I've got another nauseous medication. And now, right, this polypharmacy is a huge, huge problem for our seniors. And when we look at the hospitalized care, when we look at ICU management, sedation, delirium, cognitive changes, anxiety medicine, the medications that are on in the hospital, this is a huge opportunity. It's a huge problem, but it's a huge opportunity for us as the team to really grasp, through this age-friendly care, better care for our patients who are in that 65 plus. This is good for all patients, but particularly in our older patient population. Frailty and mobility screening, right? This is the bread and butter, or in the UK, we call it the meat and potatoes of what we are talking about here, and what Safe Early Mobility and earlymobility.com is all about, is really ensuring that we're keeping people mobile. But as you can imagine, all of these other elements impact directly or indirectly the patient's ability to maintain independent mobility. And then we've got social vulnerability issues, right? We've got isolation through hearing loss, visual loss, inability to drive yourself, inability to get around, both physical function and cognitive function, put this age group at particular risk for isolation, which then further increases the risks. And so you see it's this cascade of problems for our elderly population, which at this point, and this is one of the big reasons for this age-friendly initiative, if we're really honest, we're not great right now at dealing with this. And many of us have elderly parents that we've walked through some of these things and seen it firsthand ourselves. And then age-friendly leadership, right? This is like any other initiative. We've got to have leadership strongly engaged. We've got to have a named executive leader. And for those of you on the call who are leaders today, thank you for joining us. This is such an important initiative, and your direct support, endorsement, resource provision, training provision, it matters. It's the difference between these programs being successful and these programs floundering. So again, understanding how all the programs fit together as a leader helps you strategically streamline your hospital. I don't know of any hospital or healthcare system across the United States right now who's flush with cash and is not worried about their bottom line, right? Everywhere. So these programs do make a difference, but we've got to do them right. So with the 5 domains, like any other project, this is not going to surprise any of you who do process improvement. The PDSA cycle is so important for this project, just like it is anything else. We've got to know where we are right now. We've got to understand and describe how our care or the intervention integrates the 4Ms. Then we've got to study it. We've got to make sure it's meeting what it's intended to meet, and then we refine it as necessary. So that, again, is not new to anybody who's been involved in process improvement of any kind. When it comes to understanding where we're at, the first thing we've got to understand is, who are our patients? Right? Do we know who our elderly patients are in our facilities? And this is just a very simple tool. You'll see different versions of this on different websites. Who are in the 18 to 64 group, 65 to 74, 75 to 84. Break them down, because the risk gets worse the older they get, right? What languages do they speak? What kinds of cultural and religious preferences do they have? What races, ethnicities do you have? What are the health literacy levels? And what are their reading abilities? So we need to understand who our patients are and what percentage of our overall patients does this impact. Now, we have to have a plan regardless of whether we have one patient or 3,000 patients that meet this need. But here's the great thing. Implementing this care is going to be best care for everybody, not just our seniors, but it meets our age-friendly requirements in the course of providing care excellence. So how do we understand where we're at right now? Do a walkthrough of your processes. Do you track demographics? If not, where can we track it? Do we capture who our older patients are? What are our current activities and services, tools, processes, resources that we do already have in place? Janice, you touched on that right at the beginning of the presentation. If you've got a mobility program, you've already got some of the elements. Do you make sure that you identify your seniors in that program? And are you looking at their frailty score? Are you looking at social vulnerability? These are the things that have not traditionally been part of your early mobility program, but it's easy to add them to your checklist for your early mobility program. If you have a safe patient handling program, you've already got elements, because you're looking at mobility, you're looking at fall prevention, you're looking at caregiver health. And so you've got a lot of the tools and the processes that keep all your patients safe. You might need to look at some additional things for your elderly patients. In terms of skin frailty, do you have slings that are less abrasive on their skin? Do you have processes in place for patients with dementia or delirium or altered cognitive function? So again, thinking about, you've already got some elements. What do we need to do to just tweak that program to make sure that we are including the specific vulnerabilities of our older patients? Can team members list the 4Ms? That's a basic one. That diagram I showed you, everybody should know what that is. Put it in workrooms, put it in newsletters, on table toppers. Make sure that everybody in your organization knows what those 4Ms are and can give a description of how care integrates and aligns with the 4Ms. How do we ascertain what matters to our older adults? How do we know? Are we specifically asking them? Do we have a spot in the documentation where it says, what is this person's preference? What matters to them? How do we ensure medication is optimized? What checks and balances do you have in place? Many of you already have this in place, and it might just need fine-tuning. How do we incorporate mobility into daily care? That's a big one, right? That's most of you on this call. We've had conversations, or this is a big piece of what you're trying to do already. How do we measure mentation? How do we capture that? What's working well and what do we need to improve? Another good way to do this is take an elderly relative through the system. Take them on a field trip to the ED, or if they have to go to the ED for something anyway, go with them and look through their eyes. Is the text really small that you can't see it, right? I have to wear glasses and it really annoys me that I've got the reflection of the screen off my glasses. But if I take my glasses up, I can't read the presentation to you. So again, thinking about the things that are inconveniences and then the things that are true barriers to them getting proper care. Do people speak slowly in a way they can understand? Do they speak their language? Do they take the time? Time is really, really hard, isn't it? All of you in healthcare right now, it's probably the biggest thing I hear. We don't have time. But the thing that our elderly patients need is time to listen. They speak. If I go through the rest of this presentation at this speed, how many of you will still be with me in 2 minutes? Right? It's hard to slow down and listen, but these are the things that are really, really important in our healthcare for our elderly patients. And so again, you've probably already read through this whole list as I've been talking here, but these are the things that are going to help you show your compliance. So tracking and documenting measures, we've included in the resources at the end of the slide a really good Excel spreadsheet that covers about every measure, every potential outcome you could track for this initiative. But these are some that are most frequently looked at anyway and will count towards your age-friendly measures. So if you're looking for just a couple of measures, these are ways that you can show that you're complying. And if you have these measures and you track them, you can confidently attest at the end of 2025, we have that domain covered. So 4Ms in SECM. So you're familiar with the other 4Ms framework. For earlymobility.com, we just take it a little bit differently. And we say when older patients walk in, they expect to walk out and live meaningful lives. That's what matters to them. They don't expect to leave the hospital not being able to walk when they came in with pneumonia and were walking at home before they came in. That is not meeting what matters most to them. We hope to create a culture where mobilizing patients safely prevents falls, prevents dizziness, delirium, hospital-acquired deconditioning, so that they can live those meaningful lives, whatever meaning means to them. Age-friendly medication means we want them to be mentally sharp and able to move, right? If you're mentally sluggish or you're cognitively impaired or you're dizzy or you've got a brain fog, mobilizing safely becomes more difficult. Paying attention to all the different things that are going on around us becomes more difficult. And if you think about this, and you may know people that you've seen this in your hospitals, in your families. What happens when you're walking a patient down the hallway, an elderly patient, and you ask them a question? How often do they stop, plant their walker, and then they turn their head because they cannot process multiple things at the same time? Well, the more medications they're on, the less easy it is for them to do that. That puts them at more risk for a fall if they try and keep walking and somebody asks them a question, or the doorbell goes, or the dog barks, or something else happens. Medication is huge for our elderly patients, and we can change a lot with what we're doing with safe early continuous mobilization. Mentation, again, that is related to the medication. We just talked about that. And here's another little nugget. If we keep moving, it improves our cognitive abilities. That's for all of us, folks. If there's some of you on here who are 21 years old, all the way up to, the 91-year-old gymnast and beyond. Moving helps our brain, whether we're exercising at the gym, lifting weights, whether we're running, whether we're walking, whether we're doing squats, whether we're getting out of bed and just sitting at the edge of our bed. Moving helps oxygenate our brains every single time. So again, All of these things are interconnected. So what is safe early continuous mobility? Some of you on this line, I have recognized some names, you could say this in your sleep. But for the purpose, for those who have not heard this, it defines a culture where every patient is mobilized early and throughout their day. That takes care of the mobility piece. It also helps the mentation piece. Across all care settings, this is one of the biggest difficulties for our seniors, is navigating our complex care system. And transitions of care for our seniors, that's like dropping them into a big black hole. And they've told us that it is very scary trying to navigate. So we want to make sure that those transitions of care are really well managed. And we look at it from a mobility standpoint first. But as we're looking at mobility, we can implement all of these other elements as well. Risk factors. In addition to the immobility factors for everybody, increasing comorbidity, frailty, decreased intrinsic capacity. That means we don't bounce back. The older we get, the less our ability to bounce back, and each hit creates a little bit less resilience, a little bit less of a bounce back, and a decrease in intrinsic capacity. So this is really, really important. And as we have the graying of America and the world, it's not just America, the cost of care, the cost of unwanted care for many of our patients. They oftentimes, as providers, we want to do everything possible to keep them at their highest level and do all, and sometimes patients just don't want it. And so that's part of respecting the wishes of the elderly patients to say, I'm good with knowing that this is not going to get better, and I'm good with this level of function in my life, and this is what matters to me. How do we ask that, right? What are some ways that we can ask that? We want to understand what your health goals are and what matters to you, so we can be sure the care we provide lines up. We don't need to go through all of these, but sometimes we trip over our words in healthcare, and it's really nice to have some scripting, some guidelines as we're implementing this. And if you've got this in a guidebook and somebody comes in and says, what are you doing for age-friendly care? You can show them this stuff, and that's going to meet your compliance. So what is SCCM at a glance? And I know the text is a little bit small here, but really patient and family preferences are at the center. And we start looking at prior level of function. What could you do before? What matters most to you? How do we make sure that anything we do with mobility and SCCM lines up with that? Functional reconciliation. Are you at your baseline right now? What is our discharge plan? And what do we think you're going to be able to do by the time you discharge, given what you can normally do and your current presenting condition? And again, does that line up with what matters to you? We're going to identify and plan for precautions and barriers. We're going to address medications to make sure that you're not sedated too much, you're not having too many different medications that make you dizzy, that cause you orthostatic hypotension. We want to make sure you don't fall when you get up. We're going to make sure we do a mobility screen so that if you are at high risk and we cannot change the medicine because that is a necessary medicine, we're going to implement with safe patient handling tools to make sure that you're safe while you mobilize, because we know that with all the medication and with all the things you're dealing with, every day you stay in bed as a senior can be catastrophic for you. One day in bed for a senior can lead to 2 to 3 weeks to recover. It's so, so important that we remember that as we're making care decisions. And if they're high fall risk, you use your safe patient handling tools to get them up safely, because leaving them in bed causes harm. And then we're going to perform the mobility and we're going to document it. One day makes a big difference. Many of you have seen this calendar. So as you're getting your milk and picking up your kids, make sure you remember to mobilize your patients as well. But I'm not going to go through the whole thing, but I just want you to see on the first page, and this is a poster that you can get right from our website. If you would like a copy of this poster, it's probably one of the most impactful posters that we've created for our teams, because it shows the teams what happens within the 24 hours. And yeah, 1 or 2 days in bed does make a big difference, a huge difference. And the older we are, the bigger difference it makes. Mobility truly is medicine. We can stretch. I love this picture because the nurse is stretching right alongside her patient. That gets employee wellness covered as well as patient stretching, and it adds an element of fun. Why not do the YMCA, right? Use it or lose it, and mobility truly is medicine. And bed rest should be the exception rather than the rule. A lot of detail on this slide. These are the teams that come together to ensure that these programs are fully integrated. And if you've got this in place for your safe patient handling or your early mobility team, then the same team is going to be implementing your age friendly. So again, you've already done a lot of the work. You just need to show it. And you'll see here that senior leadership is among all of the team members that are directly or indirectly responsible, but the role is so, so very important. Different ways that we can build mobility in. We've got repositioning in bed. And for those of you know me, I'm a little bit of a geek when it comes to this stuff, or maybe I'm a big bit of a geek, but little ditties help me remember, right? Please help me keep my muscles strong so I can go home where I belong, or wherever I want to live, or the highest level that I can live according to my abilities, my frailty, my mentation, the things that we're trying to help them preserve. So we want to build recovery moments in throughout the day, not just walking down the hall one time and then sitting in a wheelchair or laying in bed the rest of the day. My goal is to get back to health. Please help me do things for myself. We've got to let people do as much as they can for themselves. When we do for them, we disable them, we weaken them. And so we want to be sure that we are empowering our patients to do as much as they can for themselves. Sometimes they don't want to do things for themselves. We have to balance what matters most to them with what is appropriate, feasible care. Many of you nurses are on the line are probably thinking, my patient's going to tell me what matters most to them is that I get them a warm blanket and I bring them and make them feel nice and fuzzy and warm right now. And that's what matters most to them. We have to balance reasonable expectations, right, with what is an outcome that is desirable for the patients, because we don't want to enable them any more than we want to coddle them or make things too easy. We also want to track our metrics. Whatever the metrics, we showed you a couple, you want to be able to show an inspector, show your team how you're doing. So often we implement programs and then we don't tell our staff how they're doing. This can be really demotivating for staff. They don't know whether they're making a difference. So whatever your program is, but particularly when it comes to age-friendly care, whatever your metric is, make sure that you know whether your trend is up, down. In these graphs, the green represents the goal. And so we want to know, are we getting there? Are we close? Did we drop? What do we need to do about that? Well, I'm just going to talk through a case study here, just to demonstrate how SECM helps you already accomplish your 4Ms. So Mr. Century was a 65-year-old. We use Mr. Century for a few different things. He's admitted to ICU with cardiac arrest and opioid overdose. He was immediately intubated, 5'10" and weighs 225 pounds. He's 8 days post-admission, 2 days post-extubation. He's transferred to a medical surgical unit with telemetry. History includes kidney failure, borderline personality disorder, polysubstance abuse, heroin, alcohol, amphetamines, PTSD, and reported prior falls. So many of you, and again, if you've been on calls with us the last few days, you'll have probably heard us talk about Mr. Century. He's a veteran. He's homeless, but he lives intermittently with his nearby sister. He's had frequent admissions over the last year, refusing treatment programs or housing services, but has recently begun to make and keep his packed appointments and has agreed to seeing social work. Prior level of function was greater than 8. That means, on those of you who use Johns Hopkins HLM, that means he could walk more than 250 feet. But what matters to Mr. Century right now is he really wants to get a handle on his health. The recent health things have scared him because he now sees that he's going to lose his independence if he doesn't start to make his appointments and engage with the healthcare team. So what matters most to him right now is retaining his independence. Let's go through each of the elements. We've identified Mr. Century's prior level of function. This talks about what matters, means walk 250 feet or more. Frailty score is 5. This means he's living with mild frailty, occasionally falling, he's slowing down, he needs more help occasionally. We have to identify not his languit, but his language. My apologies for the typo there. Healthcare literacy, cultural or religious preferences, and ability to understand instruction. So that all speaks to what matters most for Mr. Century. What matters most to him specifically? We ask that question. He wants to retain his independence. Functional reconciliation, we're looking at, is he at baseline? He's in the ICU, he's fully dependent. No, he's not at baseline. He may have new cognitive impairments. You can guarantee almost that if we use sedatives, and it's not just the traditional ICU ventilator sedatives, a lot of the things that will cause delirium in the acute care setting are antihistamines. Ativan is a big one. If we're using a lot of our diuretics, a lot of our CHF medicines will cause confusion and acute delirium, especially if they're interacting with other medications. So you want your pharmacist on your team to be able to look at the interactions of the medicine. What are we adding that can be increasing the risk? So that's our medication reconciliation, but we're also looking at functional reconciliation. What could he do before? What's he here for? And what do we think he's going to be able to do when he goes home? Discharge plan. Again, this speaks to what matters to Mr. Century. Are we looking at a skilled nursing facility for this gentleman? Assisted living, long-term care, rehab. Can he ever go home again? We don't know right now because we don't know the medical condition, the heart attack, how well he'll recover. This patient, he was up walking because the ICU had a very aggressive mobility program. So he was back to walking with a walker before he was discharged from ICU. That vastly increases the likelihood of him being able to go home. But again, and then we look at precautions and risks. If we leave him in bed, his risk for falls, pressure injury, cognitive impairment, further cardiac issues, his ability to ever do what matters most declines with every day we leave him in bed. If you take nothing else from this presentation, that's the piece that I want you to take. For our elderly patients, each day of immobility or over-medication drastically changes their ability to remain independent. Mobility screen, you can use a VA MSST or a BMAT. As long as you have a reliable screen and the people know how to use it, that's how you determine your appropriate equipment and how you keep him safe and the patient, the caregiver safe at the same time. Perform the mobility with appropriate equipment. So again, that gets to all 4 of your M's, and then address any pain or problems with mobilization. Again, that's going to get to all 4 M's as well. This is a video, and I'll have you actually go along the line at the bottom, Janice. And I'm going to have you stop at a couple of, stop here for a second, just a couple of different places. You'll see different tools here used across multiple care settings that can help get our vulnerable patients up. Chris here is 67. So he is not just in the age category, but then he also is bariatric. And I see the scoring frailty. The frailty score, the clinical frailty score is the one that's most commonly used, I think. I'd love to hear from you in the chat box. What frailty scores do you all use? And if you don't use one and you're looking, we'll post some of the most commonly used ones in the chat at the end. But the clinical frailty score is the one that we've run across most frequently. As you're watching this, you see a range of different tools. And let's go forward a little bit more here, Janice. These are ICU. Some of you have seen these videos before. A medical surgical unit, different tools for therapy, different tools for nursing, different tools for CNAs. Looking at, again, lots of different vendors. I know many of you on here may be vendors already. If you're not, look for these tools because they are phenomenal in helping you accomplish that mobility. Helping people be independent in ADLs, going to the bathroom, get rid of those bedpans, get rid of those PureWicks and help people mobilize to the bathroom. Using ADLs with therapy. Again, these lots of different tools here. Doing the YMCA in a lift, your spinal cord injury patients, doing bed wheelchair transfers safely for people who are high risk. Getting people onto the floor is a really good way, even for some of our elderly patients. We wouldn't dare do that without some of the equipment, but it can be a really good position for them. Making therapy fun. Right? This was in COVID where we were trying to be creative with in-room fun activities for people. And this is Chris, you see him again. He wasn't going to quit until he made that shot with a basket. So using different tools for ADLs, getting things out of a sink, taking people at home, putting them in, doing things in the kitchen, going into bathrooms, across all care settings. There are tools and solutions to help our elderly people stay as active as they want to be, can be, that's reasonable for them to be. And sometimes it's the difference between them being able to stay at home or going to institutionalized care. I think there's a little bit more at the end here, Janice, on some of the home care type things. I don't know if doing dishes was what she wanted to do, but this would enable her to do that, should she want to do that, right? Next slide, please, Janice. And again, the link to the video is in the slide deck. You can go back and look through it. And if there's any more questions, you can come back to us and ask us. You got to start with a gap analysis. You got to look at all your different programs. And these are the steps that we take when we're in a facility that will help guide a roadmap to where you need to go. We can help you with what are you already doing? What are your strengths? Who's doing what in the facility? Sometimes the siloed care leads to one person is leading one program, not having access to all the other things. So look at all the programs, not just age-friendly care, because that's how you identify what you're already doing right. Process mapping. Look at who's on your team. Do they know what their roles are? And if you haven't got a team together, you need to get a team together. One person or even two people cannot do this. It's too big and it's too hard to identify all the different system pieces. Identify your equipment gaps. Identify what your processes are that you already have in place and where you need to add more or just refine them. Decide who needs to be trained, who's going to do the training, what are you going to train on? You're going to have champions, train the trainer, unit peer leaders, set measures and process thresholds. What goals are you going to shoot for? Determine how you will celebrate successes or remediate non-performance or poor performance. Define expected practice for your teams. What exactly are you asking them to do that will help you be compliant in these areas? And then identify how you will communicate your actions across all team members. How does a new hire that comes in or the float staff that come in, how do they know what they're supposed to do with your age-friendly care or your SECM process? Janice, I'll let you finish up with a summary and then we'll tackle questions.
We've got a couple bullets here, but age-friendly care, it's not just required by CMS. It's, as you could see, Margaret was talking earlier, that it's the right thing to do for our patients, for all of our patients. And 2025 is the year where you get your processes in place. You do want to start right in January, tracking each domain, each component, and discussing with your team and leadership immediately. And then mid-year, you can do a review of what you've done and what you're already doing so that you can wrap up in late fall with attestation by your top leader before December 31st. Because come 2026, penalties begin. Another part is realizing to look at what you are already doing. Safe, early, and continuous mobility addresses all the domains and all 4 M's of age-friendly care. So if you're for those of you who are implementing SCCM, you already have the requirements in place. And the last thing I want to mention is, if you can see this, can you see this screen, Margaret, with
Yep.
the Excel spreadsheet? So
Yep.
this is a tool. If anybody's interested, I'd be glad to share it with you. This is a publicly available collection. And if you saw me playing around with these drop downs as we do it, you can select all kinds of parameters in terms of what matters, you know, what type of hospital, et cetera. And it will give you some measures that you can use. And also it gives you a brief narrative of where that measure came from. So in even the source, and see, now I clicked on the source, so you know that works. But anyway, so just a heads up, there are some really neat interactive tools out there that can help, and this is one of them. This is Johnny, he's my nephew, and he is using these scissors to cut the grass because he wants to slide down the hill and it's too long. And so I put this slide on here because I empathize with you, because sometimes it feels like we have so much to do and our tasks are insurmountable, and you'll get there. You just have the faith that Johnny does.
That's right. One step at a time, and we are here to help, and we want to help you. One thing we didn't say is that in addition to the penalties on the CMS care performance that the CMS puts out for hospital performance, it will be published on the public websites which hospitals are compliant and which ones are not as performance measures. Yes, I'm just going to respond to Christopher. How do you respond to patients that don't want to comply? So again, we've got to go back to what matters to them. And sometimes it requires a discussion, right? We take what matters to them into consideration. We help them to understand the ramifications of a decision. Like, you don't want to get out of bed today. Do you understand that if you want to be independent at home, that decision is going to make it really, really hard for you to meet your goal? And to really dive into, very often there's a fear behind non-compliance, Christopher, that we haven't fully addressed. Maybe they feel rushed by us in getting up. Maybe they are in pain and we haven't properly addressed their pain meds yet. Maybe they had a near fall last week, or somebody either dropped them or nearly dropped them, and they're worried about that. So the first thing is we try to identify what's the fear behind the non-compliance, and then just have an honest conversation about what this means for them, what it means for their family, pull the family in as well. So hopefully that answers that question, Chris. If not, please jump in again. And then, will the goals they give you in acute care be relayed to the home care team? Linda, that's one of the big things that with earlymobility.com, I think I'm proud to say that that's a really strong focus for us, is we don't just operate in ICU or acute care or med-surg. We really follow the patient across the continuum of care, and managing those transitions and relaying that information to the home care team is such an important part. We were in a facility just yesterday. I don't know if anyone is on from that facility today, but we were having conversations with the next level care physicians, from the physicians in the acute care side to the physicians in the skilled nursing side, to talk about admission criteria and communication gaps, and where were the opportunities to better communicate and refining those processes, because in our gap analysis, we'd identified that as a big gap. And from acute care to home care, we work with quite a lot of home care teams to do the same thing. Who is receiving that patient in the home? How are we ensuring that that information is communicated? So hopefully that will answer that question. And again, our emails are here if anyone has more to shoot us more questions. And we'll have these posted on our website as well as the PowerPoint from today. So if any of you would like to download it, you can pop over to the website, go to the resources, and we'll have it there that you can either watch it on site. I think we can download it. I'm not 100. There's some things with web pages and downloading from them that sometimes is a little glitchy. But if anybody wants more information, please reach out to us. We are geeks for this because it's just the right thing to do. It's the right thing to do for our people that are coming to seek us to help them in their most vulnerable moments. So thank you all for attending today.